All right, everyone. Welcome back from break. I would like to invite Katie back up to the stage today, who's going to be talking to us about school-based health centers and the harm reduction and naloxone practices that are going on in Multnomah County. So if everyone can give her a warm introduction.
All right. Thank you so much, everyone. Again, my name is Katie Strawn, and I use she, her pronouns, and I'm the medical director for our student health centers within Multnomah County. Before I get started, I want to say thank you to CareOregon for inviting me to do this. I have to admit, when they asked me to do this presentation, I really pushed back. I was like, we're doing something tiny. We're doing a little bitty thing, a little bitty intervention here in student health. I don't think everybody wants to hear about this. There's so many different, amazing experts that are going to be in this room from all these different places. Am I really the right person that you guys want up here? And they were like, no, it's going to be good. People will like it. All right. And then after hearing this morning, all the different questions that everyone had and all the different, ideas and all the hearing that we are all on the same page. We're all here for the same reason, and we're all just trying to figure out the best thing to do. So for those of you in healthcare clinics, this will be really applicable, but I feel a little bit better presenting to some of the others because we have got to break these silos, and we've got to understand what resources are out there and what people are doing in other areas. So hopefully this is a little bit of a pullback of the curtain of what we're doing in one healthcare setting and may give you a little bit of an idea about, in general, where we're at in primary care, or many of our primary cares around Oregon. Okay, so before I begin, I don't have any disclosures. I am employed full-time with Multnomah County. That's it. Nobody else is paying me. All right. So first I want to start this presentation by talking about what a student health center is, or a school-based health center actually is. I've been in this role for about 2 years, and before I started in this position, I had no idea what a student health center was. And then I started talking to people and realized nobody else knows what a student health center is either. So I wanted to back up and talk a little bit about what school-based health centers or student health centers actually are and what they do, and a little bit about our student health centers. Now, I'm not going to speak for all the student health centers out there. You will find out that there's actually quite a few, but I'll talk specifically about Multnomah County. And I know that our student health centers have been in the Portland area since the 80s. We've been around a really long time. Our first health center was at Roosevelt High School up in North Portland. So we've been doing this for a while, and we're pretty familiar with the model. So a lot of the things I'll talk about are general to many student health centers, but I'll highlight some of the things that we specifically are doing. So for our health centers here in Multnomah County, first of all, we are under the umbrella of the health department. So we are considered our own little tiny health department, split up into 9 different clinics across the county. So you'll see we have quite a geographic spread, all the way from Roosevelt High School over to Troutdale, where we're at Reynolds High School. We are in 5 different districts, including PPS, Centennial, Park Rose, David Douglas, and Reynolds. And so we have a nice footprint across the county. In our health centers, we have these little micro teams that consist of 1 provider. They have medical assistants, or LPNs, to do direct support, a front desk registration, a co-located mental health counselor who is under a slightly different umbrella of school-based mental health, but also within the county. And then at many of our sites, we have a behavioral health provider. I will tell you, we need behavioral health providers right now. We are experiencing the exact same hiring crisis and lack of resources in that. But we do, when we are fully staffed, although we are small, we are mighty, and we can offer quite a bit of services. So what we actually do, we are primary care. We are a pediatrician's office right here in your student health centers. All of them are located in high schools. We have been located in middle schools in the past, but due to patient age of consent for medical care, we really found that we were best utilized in high schools. So we are located in them, and we can do name it. We can do it. Wellness exams, sports physicals, regular exams on whatever that means to you, whatever you go to your general primary care provider for, we can do, as well as handle illnesses, minor illnesses and injuries, a wide range of sexual health services and contraception, which includes same-day prescribing for emergency contraception, same-day prescribing for pills, birth control pills, patches. We put IUDs in, we put Nexplanons in. So we do quite a bit of reproductive health services, all the STI testing, all the childhood immunizations, routine lab tests, COVID testing, prescription medications, mental health counseling, behavioral health counseling. We clean your teeth, and we can do dental screenings and sealants, and that's at one of our clinics in Reynolds, but not at, we only have the cleaning services, teeth cleaning in one clinic, and then vision and blood pressure screening. So a lot of services, and that's not a fully comprehensive list, but just a general idea so that you understand that we do primary care. However, we do not take over primary care if the child already has a primary care provider. So let's say they're over at Kaiser and they have a PCP that they've been seeing for years. We don't need to take that on. We're just there to help them with what they walked in the door with to ask for that particular day. Because it may be that parent always goes with them to their primary care provider and is sitting right there, but they actually like to talk about something that they may not want their parent to be in the room for, or they may want to talk about when they're not sitting in, the same family doctor that sees the entire rest of the family. So we can do primary care, but we can also just supplement that care for kids. So what does it take to get into our centers? We try so hard to be as low barrier as possible. And I know we've been talking a lot about barriers today, but that's something that is one of our mantras is say yes to care, say yes to care. We really, really, really want to see these kids. So we will see any child in Multnomah County, whether they are enrolled or whether they are not enrolled. They do not have to be in school. They can be in alternative schools, they can be in homeschool, they can be in no school at all with no intention of going to school. We do not need them to be in school. So the only eligibility is that they are either in Multnomah County living or in school in Multnomah County but living outside the county. Really, we will do basically anything we can to find an excuse to see that kid if that kid wants to see us. And we don't ask for verification of addresses. We don't ask for IDs or anything like that. None of that stuff. Let's see, other specifics. We will see kids who are going into kindergarten who are not quite 5 years old yet, and we will see kids as long as they are still in some sort of program working towards that, quote, graduation, whether they're in a GED enrolled program only and they're actually 19, or they're 20, or they just came to this country and they started school at 16 and they're going to be in school till they're 22. We will absolutely see them up to those ages. So not a whole lot of barriers in terms of eligibility. So if you're thinking, wow, this is really nice, but I wish I had a school-based health center near me because I'm nowhere near Multnomah County. Well, you actually probably do have a school-based health center near you. Currently, at last count, and this is as of July 2023, there are 85 school-based health centers in the state of Oregon right now. So that's a lot of really tiny writing on there, but if you can pull the presentation up later, you can actually see which ones are within your districts. So many student health centers actually have medical sponsors. So for instance, Multnomah County is our medical sponsor, but we are not the only student health centers here in Multnomah County. OHSU sponsors the student health center at Benson. Let's see, Virginia Garcia has a student health center here in Multnomah County. And then Wallace Medical Concern just became the medical sponsor for a new student health center they're building at Gresham High School. So they typically have a medical sponsor, which is nice because you have access to the resources of that healthcare system. Okay, so in addition to a student health center, this is where people get really tripped up. And don't worry, there's lots of words on here. You don't need to read all these words. But everyone thinks a student health center is a school nurse. What's the difference? Why do you have two of them? Or aren't they the same thing? What's the deal? So no, they're not the same thing. Yes, we like to work together, and we actually do really well when we work together. So student health centers, as I mentioned, we are a healthcare clinic. We provide the same services that any PCP would. A school nurse typically is focus quite a bit on screenings, finding out barriers to learning. They can administer some medications. They support education processes through getting IEPs and getting students through that, do lots and lots of health screenings, et cetera. But we work directly with them to find kids who are at risk, who have gaps in care, who may have specific needs that they aren't able to get. So we collaborate together, and there's a lot of evidence and a lot of research has gone into this to find that when you actually have a student health center and a school nurse in your community that are working together, you can actually detect health problems faster, and you can enhance student outcomes or youth outcomes when you actually have that collaboration together, which is really nice. Any questions on that? I feel like, yeah.
The student health care, I want to ask, the student nurse and the student health care, is they all in the same building at one time?
Great question. So the way that it is usually structured is that in a perfect world, yes. The school nurse is oftentimes even in our clinic. Is located in our clinic. They just do slightly different things. But school nurses are employed under the school themselves. They're within the school wall. Student health centers are typically employed by a medical home. So for instance, the health department. Sometimes they're in the same schools, but oftentimes they're not. So in a high school, there's always a student nurse there. But we see kids from middle schools and we see kids from elementary schools who may have a student nurse there, but we're not actually located there. But those feeder schools will send to our clinic.
Where are they from, those student health centers? Where are they found if they're not in school? Where are the places at?
You mean like who's sponsored, like who's? So our current ones in Multnomah County are in Roosevelt High School, Jefferson High School, Franklin High School, Cleveland High School, McDaniel High School, Park Rose High School, Centennial High School, Reynolds High School, and David Douglas High School. I hope I got them all for any of my staff that watch this later. If I forgot you, I apologize. So yes, so there's 9 of us, and again, there are other ones in the county, but these are the ones under the Multnomah County umbrella, so thank you. Any other clarifying questions? Because I feel like this is always just a confusing point. Okay. All right, so some unique features of student health centers that are probably different from your primary care provider. So I mentioned briefly when I was on stage earlier about youth-friendly services, and this is not a term I invented. This is a term that is widely used for people who work with adolescents, but what it takes to be, quote, youth-friendly. And there's a couple different pillars of that, and one is accessibility. So student health centers or school-based health centers are exactly what they sound like. They are in the schools. So we have a really unique access point to youth. If a kid doesn't show up for our appointment, we go down the hall and we go get them. Or we send, whichever TA is working or whatever that process happens to be in the school. But we have a direct line to that kid. And if that kid didn't show up that day, we can talk to the front desk and say, hey, we have a kid that's actually not shown up for several appointments. Are they still, what's going on? Have they not come to school? And we can actually figure out oh, they've dropped out. Or nobody's seen them in the last week. So we can then work with the social worker. Hey, let's talk about what's going on. We have concerns. So we have a really nice line, not only to the students, but to a lot of the resources that the school have. And schools have a lot of resources. Do they need more? Of course. But they do have a lot of resources. So that physical location is really, really key. And several of our clinics, kids are being brought to school, so they're being brought to us. It's the accessibility point is really a key part of a youth-friendly service. Same-day appointments, the accessibility, again, half of our schedules every day are blocked for same-day appointments. So if you want an appointment that day, if you call in the morning, you will get an appointment that day, which is pretty unique. It's hard. I mean, how many times right now are we calling our doctors and able to get in the same day? It's fairly unusual. Not to say that it doesn't happen. But we do really save a lot of our access for same-day appointments. And again, as I mentioned, we have a direct line to those additional support services. We do have, they're not necessarily physically located in our clinics, but we do also have a few other services that we offer to clients that are under our department, including a community health worker who will go out to the community and deliver those medications to the client's home. They will, if we have a kid who is, needs to go see their cardiologist or needs to go see whatever specialist it is, and they're really nervous and concerned, our community health worker will set up that transportation, and then we'll meet them at that doctor's office and sit with them through that appointment to make sure that they have the support that they need, that emotional support, and also that help with getting things set up. So that's one of the services that we offer, and thanks to CareOregon, we actually just got funding to get a second community health worker, which is really exciting because that community health worker is working hard. So having a second one is going to be really key. They also go out into the schools themselves and do health promotions. So every health class in the schools that we are located in actually have talks and discussions around reproductive health care, and now we're adding education specifically around overdose prevention and harm reduction programs, which I'm not going to talk about that specifically today, but that is a new education piece that our community health workers are going to be doing. And finally, we have eligibility specialists in our clinic who are scheduled to come sometimes in clinics once a month or so, but they are always available by phone. So if a client comes in and they are uninsured, we will get them connected with someone who will get them enrolled into CareOregon, OHP, whatever service, whatever coverage they need or they qualify for, which is really, really helpful in getting some of those additional specialty services. Confidentiality. This is huge. This is a huge pillar of youth-friendly services, and it is a huge part of the work that we do. In the state of Oregon, and probably everybody knows this, but in case you don't, in the state of Oregon, at the age of 15, you can consent to your own medical care. And you don't need your parent to be there to give you permission to do anything. Now, we always want to involve the parents when we can. We always want to ask, get more information on if they don't want to involve the parent, but we respect their autonomy to make that decision. And we respect the fact that they are coming into our clinic to get medical services. We congratulate and empower them to continue to come back to make their own decisions about their medical care, which is a really, really fantastic thing. And really, I think, gives kids a real sense of pride that they can take care of their own medical care. We have kids who come in who, I haven't been to the doctor in 3 years because my parents, can't take off of work. And I'd like to come in and I'd like to get a physical. I'd like to catch up on my immunizations. I'd like this. In the state of Oregon, you can consent to your own reproductive health care at any age. And so we definitely see lots and lots of kids for reproductive health care. And then mental health care, you can consent to your own mental health care at the age of 14 and older. So working within the confines of Oregon state law, we really try to reduce all of those barriers. Every single client, when they first come to our clinic, we have a discussion about confidentiality. We will keep your information confidential as long as it doesn't cross into a safety issue. Crosses into a safety issue, we definitely have to talk about what breaking confidentiality is and what that looks like. But that we are clear and transparent with kids right up front about those things. And then finally, and most exciting for many people, is we have absolutely no out-of-pocket cost. Our services are completely free all the time, no matter what. We don't have any way to collect money. We couldn't take money if we wanted to. We don't want anything. We want no part of collecting cash in clinics. But we can bill insurance, but we absolutely do not have to. So if a client is concerned about, hey, I have MODA, or I have Blue Cross, or I have CareOregon, and I'm worried about an EOB going to my home, like an explanation of benefits, we have a way in our EMR that we block it. So it does not go, so that it cannot see it. So that doesn't get sent out to and billed to the insurance companies, which is really nice. So all of those things really set us up as a nice place for youth to get services, relatively low barrier. So we are a primary care clinic, which means we do a lot of screening. A lot of primary care is just screening for additional things. So we screen for all sorts of things. We screen for lead poisoning, and we screen for blood pressure. We screen for all those things, but we also screen for high-risk behaviors, including substance use, riding in cars with people who use substances, do they have guns in the home? So we screen for all of those things, and there are some real specific screenings out there that are absolutely not unique to us, that are being used across primary cares all over the place. But some of just the standard screenings that we use are the SBIRT and the CRAFT, and we're gonna talk a lot more about those. We just screen for depression, anxiety, social determinants of health, that's what the SDOH stands for, suicidality, we use the Columbia screening. So these are all things, these are general screenings, and all of these are recommended by the American Academy of Pediatrics. The problem is, in many primary care clinics, screening is not actually done, and they don't use any particular forms, especially for substance use disorders. So what we found, one study out of Massachusetts found was that while about 70% of primary care providers were asking about substance use, less than a third of those were actually using any sort of standardized tool. They were just kind of like, hey, do you use drugs? Hey, are you using cocaine? And we know that you do have to use some sort of validated screening tools. And so we typically use the CRAFT, and I think the CRAFT is likely the most common one that's out there. The lit review that I did for this, it looked like the CRAFT was far and away the most common one. And for anyone who hasn't seen the CRAFT screening tool, this is likely what the adolescents going into the communities, these are the types of questions that they're getting. Do you drink more than a few sips of beer? Do you use any marijuana? Do you use anything else to get high? Do you use a vaping device? Have you ever driven a car? And that's it. There are additional questions that ask, do you use a loan? Do you have family or friends who said they're worried about you? Have you ever felt like you can't stop? Those things. But it's fairly basic. And then the PHQ-2 is a depression screening. These are the other ones. Do you relax? Do you ever use alcohol? Do you ever forget things? So these are the kinds of questions that the kids in the community are being asked about right now. So here's where we sort of pause. This is what we've been doing for many, many years. This is what most primary care clinics are doing. And 2 years ago, we had 2 student fatalities at one of our high schools. And they were kids who bought pills, thought they were one thing, took them home, both of them to their separate houses, took them, and they died. They were found dead by their parents. And that hit our program really, really hard. And we all had to just take a step back and sit down and kind of think, what did we miss? We are doing these screenings, this CRAFT screening right here, every single time they come to the clinic for any kind of checkup, any kind of sports physical, we're asking the questions. Every year we're asking these questions, sometimes multiple times a year, and we didn't catch it. And the CRAFT is really, really sensitive. It's good at catching substance use disorder. It's not, it has an over 80% sensitivity rate. But we were missing something. We were missing where we had the opportunity to do some harm reduction. So we sat back and we just thought, you know what? We're a small clinic, we're a small group. We want to try something different. We want to do something a little bit different, because why didn't we catch this? So we looked at other tools, and there were good ones. They're decent, but most of them looked at alcohol use. They were a little bit more focused on alcohol abuse. A lot of them weren't validated for kids. So we just really didn't find anything out there that we really felt was good for our population. And for anyone who wonders what the CRAFT actually stands for, it's the car, relax, alone, forget, family, friends, trouble, all the questions that we just asked. And this is just the CRAFT sensitivity, because I'm not hating on the CRAFT. The CRAFT is a really, really, really good screening tool. It just wasn't getting us to where we needed to go with harm reduction practices. So before we kind of get into what we decided to do, I just want to talk a little bit about what we were doing. So when the kids actually screen positive for CRAFT, which is usually a yes to more than 2, or a yes, do they use it for a certain number of days. There's a new craft screening that actually, rather than asking yes, no, it just says like, how many days did you do these things? It doesn't give them an opportunity to deny that they've done it, which that's fine. And we did, if they ever screen positive, this is what we did. All right, so I see that you've said yes to smoking substances. Don't do it. And don't drive in a car with anybody that does it. And what do you think about that? Tell me. And it is your decision, though. And you should definitely come back and talk to me about it a little bit more. So that's what we were doing. And we thought we were doing pretty good. We did some extra things. We did some additional things. We did lots of motivational interviewing. I'm a huge fan of motivational interviewing, especially if they said yes. Are you ready to change? Where are you at? Why do you do this? All the questions. And I think we're actually quite good at that. But still weren't getting there. And then we have lots of behavioral health interventions. If they said yes to substance use and they were willing to talk to a behavioral health counselor, we would send them there. They would work on, all the different, behavioral health interventions that they take, try to involve parents if they were willing. They would engage with outside resources if we needed to, and doing some kind of targeted education. So with all of this, in the same year that we had that overdose, I went back and I looked and I went to go see, all right, well, how many times did we prescribe Narcan? In 1 year, how many times do you think a group of 9 providers, 40-something staff in our entire department, we service 5 different districts. How many Narcan prescriptions do you think and we were screening every year, every kid. How many Narcan prescriptions do you think that we gave? I hear 0, I hear 5, I hear 2. 1. 1. Yeah, 1. So something's got to change. All right. So you guys have been getting statistics thrown out all over the place about why we're here and the why, and I'm just putting up a different one. There is a CDC, does anyone here know what the Suitor system is? Great. It's the state, it looks like not many, 1, 2 maybe. This is and I'm gonna try to remember what the acronym is, so jump in if I don't get it right, but it's the State Unintentional Drug Overdose Reporting System. Okay, I think. Nobody look it up and tell me I'm wrong. So this is a reporting system that this tracks unintended overdoses across the country. It's sponsored by the CDC, and so states go in and they pull data from EMRs and they find out how many people have actually had unintentional overdoses. So we found out that among persons 10 to 19, between the 2019-2022 year, or 2021 years, that deaths from unintentional overdose in our population increased 182% as a general median monthly average. That's a lot. That's a lot. And we're going to talk, I'd love to hear all of your explanations of why you think that is. So that's coming. So be thinking about in your head the reasons why you think that this is happening. But just FYI, about 90% of the overdose deaths involved opioids specifically, and I know fentanyl is an opioid, but primarily involved illicitly manufactured fentanyl in some way, shape, or form. So fentanyl specifically. So they're calling out fentanyl. We all know that fentanyl is a big, big issue. Only 35% of kids who passed of unintentional overdose had any documented opioid use history. So we're not capturing it. We haven't figured it. We have not cracked this nut yet. Of that 35%, well over half of those kids had either already had an overdose before, so they'd already been seen within the system, so we hadn't caught it first, or were in the juvenile justice system. So it wasn't coming from general primary care practices where we're the ones who are supposed to be catching these things and catching these high risk. So why is this happening to our youth? And I know we've talked a little bit about this in sessions, and I don't know if we've opened it up to the audience before, but I'd love to hear from all of your perspectives why. Why over the last few years is this happening? Yes. And I'll just repeat what you're saying. I can just repeat if you're just gonna.
Yeah, so I think a big part of it is like the U.S. is like the second nation in the world where medication companies can advertise directly to the consumer. And so in a lot of ways, as we grow up, conditioned to lean into a pill. I think that's a big part of it. And I also think the other part of it is like, as a culture, we do not understand pain and how to express it and process it in a way that feels holistic to our own bodies.
So the two part of that, and then yes, maybe we will pass the microphone around. No, it was a really good answer. Part of it was our capitalism and our culture of advertising and being able to advertise direct to the consumer, and also our very poor understanding and management of pain in our country. I think those are excellent answers. Other reasons why this is happening to our youth, and why over the last couple years? Yes, and the microphone is right behind you.
Increased access, especially to recreational marijuana. And then also just thinking about the pandemic, I feel like I'm always just giving a lot of space.
We can blame it on everything.
No, but honestly, if you think about it, kids have a lot more time at home to access their parents' whatever substances that might be available to them, on top of the fear and anxiety of the pandemic, on top of the fear and anxiety of being a teenager, and then all the intersections of the identities that those teens have. So yeah, it makes sense that a lot of kids are using in order to kind of numb or quiet those anxieties.
Anyone else have any thoughts on why? And there's not like one right answer. I'm not about to like reveal something amazing to you all.
Adolescent development. If you tell an old person your behavior is making you unhealthy or unsafe, they get really cautious. If you tell a teenager, "Ooh, that's dangerous,"
You're like, give me more.
yeah. I mean, it's the era of risk taking and risk seeking, and I think some of our messaging. We have to spend less time on, oh God, don't do that, it's unsafe, because that's actually sort of interesting to a youth.
Mm-hmm. Any otherwise, I love like the wide range of reasons. This is fascinating. Anybody else that wants to? And I have some thoughts. So one of the one thing that research has shown is, to someone's point, accessibility, specifically social media accessibility, and the huge amount of social media usage that kids use these days. So social media is big, and that's access to purchasing, those connections, accessing people who are also interested. So social media and unmonitored social media use is a thing. The other one is the mental health crisis, and that due to the pandemic, the mental health crises have exploded, and there's lots of different reasons around that too. Potency of drugs has gone up. They are just more dangerous. Because actually, if you look at the data, there's not actually more users out there. The number of people using drugs has, in this population specifically, in adolescent populations, hasn't necessarily gone up that much. But it's the drugs that they're taking are more likely to kill them. And that's really, really scary. So we decided to design an intervention to figure out what sort of harm reductions we can do. And we really needed to approach this first and foremost from what we are good at, what we know how to do, what we can do in primary care. Because as the medical director, it's really hard to change things. And it takes a lot of time, and it takes a lot of energy, and it takes a lot of resources to blow up the system that you're in and start a whole new system. So first, let's start with what we can do and what we can change. So we know we're really good at screening, we know we're good at education, and the kids are at school. They're there to be educated. They are ready. They know that you are an adult and you're going to tell them the things that they need to know. So we are primed and ready to educate them. And we can dispense. All of our clinics can dispense. All of our providers have licenses to prescribe, and about half of them have DEAs. And actually, no, that's not true. We all have our DEA licenses now. And we can all dispense. And we have it set up with the Board of Pharmacy that we can actually dispense directly from our clinic, which is slightly different than like you go to the doctor and they write a script for you and you go to your Walgreens and you pick it up. That's prescribing. Dispensing is you go to the doctor and you ask for a medicine and they hand it to you and you walk out. So we can dispense medications, which is really nice. One of the other pillars of youth-friendly services is same-day care for what they came in to ask for. So how many of you have actually gone to your doctor's office and said, I really would like to, I think that, whatever, my hair is falling out, and I think I'm going bald. I'd really like to have a prescription for this. And they say, yep, okay, well, we're right at the end of the visit, so can you come back and we'll talk more about that later? And they'll make you another visit for you, and then you gotta take off time from work and actually go back to the doctor's office and talk to them about that. And then 4 more visits, because then they gotta check your liver test, and then they gotta check your kidneys, and then they gotta, oh yeah, you're actually due for your annual exam, so we're gonna do that, and why don't you go to the OB and get your PAP first, and then we'll talk about the thing that you actually wanted to talk about, and you can go pick up the medication. So we all experience this, but with kids, with youth, they're interested in that moment. If they say to me, if a kid sits down and says to me, Katie, I'd like to be on birth control, they will walk out with a prescription for birth control, or will have a birth control prescription in their hand or an IUD in them. Same day care is vital in kids, because an hour later, they've completely forgotten about what was very important to them at that moment and right in front of them. And you can make an appointment for them, and many of them do come back, but a lot of them don't. So in our school health centers, we try to address exactly what is going on with the kid right at that moment, because we are not guaranteed another visit. We're guaranteed the time that we have right then and nothing else. So we gotta get done when we gotta get done. So we can dispense. So we decided, you know what? We really like the craft, but we're not really asking we just want to ask the direct questions. We know that from communication with kids, there's lots of research on this, how to communicate with kids, especially adolescents. They just want you to ask them. They just want you to ask the question. They don't want you to say, hey, are you using that white powder that goes up here? Do you know anything? They don't want indirect questions. They don't want euphemisms. They don't want that. They want you to ask them directly what you want to know. And if they don't want to tell you, they just will say, I don't know. And if they do want to tell you, great. So we decided to just write our own and study it and figure out if this was at all helpful. So we ask now 2 questions. Do you think you may be around anyone who uses drugs or medications without a prescription? And are you interested in receiving a prescription for Narcan today? And kids over 15, every kid gets asked these questions. And the beauty of it is, well, we also ask these questions. I forgot I put this slide in here. So along with the screening, we do a couple of different things to screen. So we do have screening criteria for clients. And the provider every day before they start their day will look through the chart and look through if a child has any of these specific things, like if they're taking prescribed opioids, any illicit use, any use of any medications, any ER visits, following any kind of opioid poisoning or intoxication, or really in any drug ingestion or intoxication that leads to an ER visit, and then any positive previous CRAFT or SBIRT screenings in the last year. So we're looking just generally, what kind of risk are we looking at? And then our medical assistant goes through before the beginning of every visit and actually scrubs the schedule to see when was the last time we even did a screening on this kid. And so whether they see this or whether they haven't been screened, we just put it right there on the appointment note. Needs Narcan screening. Doop. We just NS on our little appointment notes. We use Epic. So that we know that's something that we've got to ask today. So scrubbing and actually looking for and making this a priority was step 1, and then actually knowing who we were going to screen. So what we did is we actually divided our clinics. I have 9 clinics, and we divided them into 2 groups. So group 1 decided to do universal screening on all children 15 and over during their SPE, stands for sports physical exam, and their well child checks. So every kid 15 and older, every time they came in for a well visit, they're supposed to come in for a well visit once a year. So roughly once a year, every kid 15 and older got asked these 2 questions. In group 2, we decided to only ask these questions of kids who screened positive on craft. So using the questions as a reflex. So if they screened negative for the craft, we didn't ask them. We just moved on and moved on to whatever else was. But if they screened positive, meaning they had at least one yes on there, then we would ask the screening questions for Narcan. So we decided just to see, what's the difference? Do we think that it's more effective to just screen everybody and capture everyone, or do we think that it really is probably more of a high risk? Because I'll be honest, when I rolled this out to my providers, they were like, I don't want to ask any more questions. I don't want to do anything else. Like, it is hard. It's hard to see kids back to back to back in a short appointment time and capture all the things that you need to capture, and asking anyone in healthcare to do anything more than what they're already doing is really, really hard, and it doesn't feel good. So we decided, we would like to do the amount of work that we need to do to get the results. So this is our screening tool, and this is available for anyone, and I know it's teeny tiny and you can't see it. But this is the screening tool that we hand the kids. So the schedules are scrubbed, meaning we look through the charts, we do chart reviews. Then we put on the appointment notes that they need a Narcan screening. And then the medical assistant, when they're rooming the kids, puts this screening tool in their hands and says, can you please fill this out? We don't require them to. Before they get the screening tool, we talk about confidentiality, like I mentioned. So they know that going into this is a confidential talk unless they tell us something that we're now worried about their safety. So they've already gotten that piece of it. So now we give them the screening tool, and all of this information is on the screening tool, and then they're just left alone in the room. And sometimes kids actually read what you put in their hands and you tell them to do, and so they're just sitting in the room and they're waiting for the provider. So a lot of times they'll sit there and they'll actually read it, because you ask them, like, are you interested in receiving a prescription for Narcan? The very first question that half of them ask you is, what is Narcan? So they have it sitting right in front of them. We also have a little QR code down here that actually takes them directly to a video that shows them how to administer Narcan, and it's about a 3-minute video. I will tell you right now, it is not a great video. It's fine. We are working on actually creating our own video, because I found out when I was putting this together, I could not find a single video that actually had youth in it. It drove me. It was very frustrating, and because it's all these adults I'm here to help you, and I will start CPR, and it's I am not telling a 15-year-old to do CPR on anyone. That sounds terrifying. But rescue breathing, that's possible, and giving Narcan, absolutely possible. So really hard to find a video. So we're making our own. So don't hold this video against me. It's fine. It gets the job done, and we will have a better one. So the provider walks in. And at the beginning of the visit, they take all their screening tools, all that paperwork, and they look at it and they say, oh, you didn't fill this form out, because they never do, and that's fine. And they say, yeah, I don't really know what Narcan is. And then we tell them. And we just real briefly, we don't go through all this, but this is what it can do. It can save your life, or it can save your friend's life. And we really talk about it oftentimes from the lens of their friend, because if you're giving Narcan to yourself in an overdose, you probably don't need Narcan, but maybe you're just about to go out. But we really come at it from, are you having risk-taking behaviors with friends, or are you around people who use drugs or medications? We don't use the word risk, but are you using any drugs or medications, or do you know anyone that uses any drugs or medications? And we know that from extensive studies of reproductive health care and risk and high-risk sexual behavior, that kids are a lot more likely to tell you what their friends are doing than what they're doing. It's fascinating. And yet there's a lot of research to show that whatever your friends are doing, you are doing. So we can kind of put 2 and 2 together. And I see a question in the back, so I'm going to pause. I don't know if you need a microphone. Hold.
You were saying that a lot of the youth don't even know what Narcan is. Shouldn't that be screened to everyone then, so that they at least know what it is then, to like give them the information?
We absolutely are looking at expanding this screening tool to younger than 15. The reason why we decided to start with 15 is because they can make their own medical decisions. Under 15, we can't prescribe or make a treatment plan without talking to the parents. The parents are the ones who actually have to consent to medical care. And if you don't agree with that, then talk about House Bill 2002, which just passed, that did actually have a lot more language in there around dropping that age of consent for specific things like gender-affirming care, reproductive health care, abortion services, et cetera. So anyway, it's a discussion in Oregon and will continue to be. But that's why we chose 15 and up, but really excellent question. Anybody else have a question? Okay. Okay, so the beauty of this is that a lot of kids, number one, they're saying, I don't know what Narcan is, and we get a chance to tell them what it is. If they take a Narcan prescription, great. If they don't, they now know what it is, and they know where to get it, and they know that it doesn't cost anything, and they know that we're not going to tell anybody. So it's been really, really helpful. So that education piece was part of our intervention. They actually go home with this tool right here with all the same information that they sit in the clinic with and have. So we just send them home with the tool afterwards. We did end up embedding this flow sheet into our EMR. If you have ever used Epic, Epic is the most common EMR, I think, certainly in the city of Portland, but we decided to just embed it right in there. And so we are now tracking not only if they dispensed Narcan, but if they received education on Narcan. So the data is not in yet, the report hasn't been built, but we're gonna see how many kids in Multnomah County that we saw actually have received Narcan education now. So we're excited to see what that data is gonna look like. And providers really liked this because then it just pulls right into their clinic note, and anything that you can do to decrease the amount of documentation that they have to do makes them really, really happy. Okay, so dispensing. So we decided as part of our intervention, we're gonna have Narcan there and we're gonna be able to give it to them that day. If they wanna walk out with it, they can walk out with it. So we now have it stocked in every clinic for same-day dispensing. And it is actually not required that you have to be trained to give Narcan. We do train you, but you don't have to be trained. I just want to throw that out there for everyone. It's not required as part of Narcan prescriptions or administration. So it's stocked, you can have it, you can walk away with it. Because of, and I know you guys are saying, well, why don't you just put it in a basket, put it up front, and they can just come and get it whenever they want. And yes, that would be nice. The reason that we have to do this is because of the purchasing program that we purchased our Narcan through, which is called the 340B program, which is a government subsidized drug program. I can tell you all about it later if you're interested. But it requires any drug that you give as part of a 340B program, it has to be in conjunction with a provider visit. So we get it at a reduced cost, but it does require that they talk to a doctor. And we do want to tell kids how to use it. Makes sense. Okay, I'm gonna back up for a second and just make sure everyone in this room knows what Narcan is. I suspect that you do, but we'll talk about it. And yes, I saw a question before I forge ahead. What time? 10:50? Okay.
Just have a question about the Narcan. Mm-hmm. Would it be also proactive to have it in emergency rooms, like as a routine, distributed by the provider when a teen comes in with an overdose? I worked in an emergency room, and that is not a routine.
I would love that. It would be great. Yeah, I don't think most emergency rooms are set up specifically to dispense. It's more to prescribe, and there is actually a huge difference, and there's different licensure with the Board of Pharmacy around dispensing versus prescribing. So you have to get a special license from the Board of Pharmacy to dispense medications. So you can't just, in your primary care clinic, decide that you're just gonna start, giving everybody a dose of Tylenol or whatever it is, even if it's over the counter. Yeah. Yeah. Any other questions? Okay, so just to make sure everybody here kind of level set with what Narcan is and I'll talk about exactly what it is, but just so everyone knows it's safe. These are some main highlights that we tell kids. It is safe. You can give Narcan to anyone, and if they're not overdosing, it doesn't do anything. I have given it to a kid who I thought was overdosing, and they're like, ooh, that smells terrible, that once they came to, which they came to for different reasons. And I have given Narcan in the clinic for kids who come in and overdosing in school, by the way. But it's safe. It's safe to give, and I think that's what most people are concerned about is, I don't want to just give a drug to anybody. I don't know their medical history. I don't know what they're allergic to. Almost nobody is allergic to Narcan, and the only contraindication or the only reason that you really can't give Narcan is if they have had an anaphylactic reaction to Narcan in the past, and there's very, very, very few documented times that that's happened. It has a really low side effect profile, which means it doesn't have a lot of side effects, and the side effect that it does have, which is opioid withdrawal, is kind of the point. You want them to not be experiencing the feelings of opioids at that moment, so they will start breathing again. So it's a really safe drug, and it's super easy to give. Narcan specifically just goes whoop, one little squirt in the nose. And then you usually get 2 doses in the package, and if it doesn't work after 2 to 3 minutes, you put another squirt in the other side of the nose, and then hopefully they start breathing in the next minute or 2, but if they don't, then you do some rescue breathing. And before you start all that, you call 911. But it's fairly easy. You all now know how to give Narcan. So it's an easy thing. And I will just say, because there's sometimes confusion about Narcan versus Naloxone. Naloxone is the generic, Narcan. Narcan specifically is the spray. You can also give Naloxone intravenously. So they're the exact same medication, just different routes, essentially. Did you ask if a pregnant woman gives it, could the child become addicted? Nope. Pregnant women can have it just as much as anybody else. Yeah. Any other questions? Okay. Oh, yes. I have not heard specific. Yeah. Oh, has there been any discussion around routinely giving the 8 milligram versus the 4 milligram? Because this is a 4 milligram dose. I would say no, I haven't heard the discussion specifically around giving 8 milligrams as a routine to just start with. I think they are typically giving the 4. And I will tell you, every time I give 8 milligrams, EMT is like, you gave how much? And it's like, wait, what? What's the problem? But yeah, so right now, as far as I know, it's at 4 milligrams as the first initial dose. If anybody's heard differently, speak now. Okay. All right.
Question.
Yes.
You said that Narcan can be given intravenously with a needle.
Mm-hmm.
Who's trained to do that?
So the only people who are trained to do that in terms of in a medical setting, I believe that nurses and an RN is trained to give anything through a vein. Yes, an EMT can. Yeah, absolutely. Yep.
So they're the ones that have that.
Yes, Narcan is in every EMT vehicle. Correct. And Narcan was not originally we only had intravenous Narcan. That's all we had. Yes, Ellen.
You're saying intravenous, you
Sorry.
mean intramuscular.
Sorry, intramuscular, sorry, excuse
Guys,
me.
we
Thank
need to
you.
use the microphone.
Although they do both. On the streets, they'll do both. But yeah, I'm sorry, intramuscular, excuse me. Yes,
Just as
thank
a
you,
friendly
Ellen.
reminder, we need to use the microphone for our recording.
Yes, intramuscular. And intramuscular can be given by anybody who's had medical training, and you can give your own intramuscular injection. Yeah, I'm thinking specifically about the time when I'm on the street and they gave it right in the vein. So I always, went right on in there. It was terrifying. It's stuck in my brain now. So anyway, I do want to make sure that we get through these slides, but so how Narcan works is you have these little things on your cells that are called opioid receptors. They are in your central nervous system and your limbic system. And when opioids bind to them, they do things like cause euphoria, they slow your breathing down, they can cause you to feel very sedated, all the things that happen when you take opioids. When Narcan comes along, these little yellow receptors right here are more they have a higher affinity, meaning they would rather bind with Narcan. Narcan is a stronger bond with them, so it kicks the opioid right off the receptor and immediately bonds to it. It happens very, very, very quickly. So it is a very fast-acting medication. And when it kicks everything off, it kicks all the opioids off. So that's why if you give Narcan, especially in someone who has physical dependence on it, then they come out and they can experience some pretty severe withdrawal symptoms and can sometimes be very agitated. So we don't see it as much in adolescent populations because they sometimes, often the ones that we're seeing are unintentional overdoses. So I haven't seen a lot of like agitated, violent patients that come out of it, but in adults, you give it and then you step back. All right, so what have we found? And this is very preliminary, and so we haven't run all the stats on it, but I just want to give you guys an idea because we have seen some things already. So we just started this intervention really back in March. So with universal screening clinics, we saw that we had a modest improvement, or we gave slightly more doses of Narcan with the universal screening. I mean, everyone who got screened 15 and older, which made a lot of sense to me, but it was good to know. And in the risk-based one, we saw slightly fewer Narcan prescriptions. And you can just see the little tiny bar graph that you can't actually read. It just tells you how many Narcan prescriptions. So since we started this screening tool, we've seen a 1,400% increase in Narcan prescriptions, which sounds really, really impressive. And this is why you should always make sure you read the fine print of any of your studies, because it's really not that impressive. We've only given 15 doses. But it's more. It's still a 1,400% increase if you just follow the stats. So that's why it is important to read your data, make sure that when you read your studies, see like what was actually, how many did you actually give. So I put this on here because it is a funny statistic to me because it's not that many, but it is a huge improvement. So we are making strides, and we have seen that preliminarily this screening and just asking kids, do you want Narcan, results in getting Narcan. The one thing that I want to point out is that I want everyone to have Narcan, but if they don't take it, I at least want to just tell them about it. And that's where I'm excited to see what our findings are on how much education we've been giving, because even if they say no, the first question is, what's Narcan? So we get to tell them a little bit about it, which is really nice. So some challenges and things that we've encountered when we were doing this intervention. We've struggled with staff participation, and it's not because everyone's not super invested in doing this, and everybody knows that this is important work, but we got a lot of other things to do, and so it's just difficult to change workflows, difficult to get that embedded, get the muscle memory of giving the form and pushing the buttons and doing the clicks. So staff participation continues to be a big one. The flow sheet documentation, while it's great, it's still in a different flow sheet, different part of the EMR. So you still have to do some clicking into it. So we're working on figuring out how to make it a little bit more user-friendly, and that it really is just right there. Competing priorities. There's just a lot going on in healthcare right now. And when you have a 20-minute visit with a kid, you just don't have a ton of time. And so sometimes you've got to deal with what's there right there in front of you. So we do have competing priorities. And that's a big conversation in my group and my practice right now, is maybe we need to talk about what our priorities are and making sure that we're really addressing what is our highest priority. And change fatigue. With COVID especially, and on the heels of COVID, everyone is just exhausted. And we had to throw everything out the window when COVID happened and do all these new workflows, and then we had to figure out how to get everybody back in the clinic. And so people are tired. People are really tired. So limitations, and I think I'm at 1 minute left. Okay, and I think I'm just on my last slide, or second to last. All right, limitations, the 340B program that requires a provider visit only. Certainly we can't put a basket out with Narcan in it because of that. Marketing, we continue to, we did want to, since this was like baby steps into the intervention, we didn't like paper the hallways with, hey, come get your Narcan at student health centers, because one of our other limitations was some school buy-in. We do still continue to have a little bit of pushback from schools, and primarily that's around kids carrying medications in schools. So the Oregon Department of Education does not allow you to carry a medication in school without the school nurse being aware of it or really holding on to it, unless it's a life-saving medication. And yeah, I actually think Narcan is a life-saving medication, but I haven't been able to get ODE to get on the same page with me, because they also have a rule that you can't give your own medications to anybody else. So we need to carve out for Narcan specifically, and those conversations are happening. Again, there's so few adolescent-specific materials, and the big one is we have not been able to reach the truly at-risk population. These are kids that are coming to school typically, or at least have some sort of they're coming into our clinics. The kids that we need to reach are the kids that aren't coming into our clinic. So that's where I'm so encouraged and feel great about having this group right here, because this is where we can start to make those connections. So future state, we're doing a Never Alone campaign this year to really push that. Again, doing some education in our health classes and continuing to build partnerships with community organizations. I'll let you read the takeaways. The takeaways are we need to prevent overdoses and we need to do it somehow. And then collaboration among us, all the people here and educators, will help to save lives. So thank you all very, 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 very much for coming to this.